I will now call to order the regular meeting of the Watsonville Community Hospital Board of Directors for Wednesday, December 17th. Rosie, when you can, please give us a roll call.
Yes, Director Cox. Here. Director Friel. Here. Director Gallagher.
Yeah.
Director Pimentel.
Yes.
Attorney.
Here. Closed session report. There's nothing to report at tonight's closed session, and now I'll turn to staff for any agenda modifications for consideration. Yeah. Okay, seeing none, I'll move us on to public comment on matters not on tonight's agenda. I'll go out online first. Anyone joining us via Zoom with any public comment on matters not on tonight's agenda? Okay, seeing no raised hands. Anyone with us in the public wishing to speak on any items not on tonight's agenda? Okay, seeing none, I'll close down the public comment and I'll bring it back to our board members. Any comments from our board members before we get started on our consent agenda? Please.
Gratitude comments. As I continue to reflect that we're in a really stressful time, I think all of us in our day lives, night lives, child lives, kid lives, friend lives, whatever our roles are in outside of our day jobs, that's also been a stressful space, I imagine, for a lot of people. So I just want to acknowledge that these are rough moments and times. And when I see the quality of the work this hospital is still doing despite all that and all the threats, it's weird that I'm getting hope and optimism when I come to these meetings. They're often from a finance perspective, from my finance lens, they're very hard. But when I see the faces and the people who are working together to do things amazing for our community, I get very excited when I see an unexpected guest at our County Board of Supervisors meeting, Chair Nunez, speak to our board about the importance of getting us recognized as one of the funded rural hospitals, federal system grants like that. I love what we're doing in those spaces. Steve Gray participating in presenting to 100 people online and many other places about the state of our hospital and the amazing things we're doing, the presentations you do with Leadership Santa Cruz to educate most people who are from here about the amazing work that we do here. I'm going to continue to be in a place of gratitude and respect and appreciation and honor to work beside everybody. So I've been reflecting and thinking about that a lot over the last many months. I just want to put those into work a little bit more than I've done before. And Julie, you were singing today and you were singing yesterday. Like, I just tumbled to be here along with all our elected representatives who chosen to do this. And occasionally we get a cookie, and I appreciate that. Rosie, thank you. You have no idea how valuable that chocolate cookie was today. But it's an honor to work beside every one of you especially during these really challenging times.
Thank you. Any other comments from the board? I do have some, but okay. Just want to echo Marcus. You know, it's the end of the year right now. Obviously, there's a couple of weeks left before 2025 officially wraps, but it's the last time that I think publicly I can at least have some critical mass of everyone that works at the hospital dedicated to your time at the hospital. So just want to say thank you for everything. I know this year has been extremely difficult, and it goes even back into into Q4 of 2024 for all the challenges that we face. But just thank you just from the bottom of my heart. And I want to let you know that we're all in this together, right? We have been since the very beginning. We knew that the challenges can be very difficult. We knew that this is going to take everybody in order for us to turn this hospital around. And I feel like we're making progress. And every time that we get to these meetings, and like Marcus said, you know, the challenge has been very difficult this year, right? And from a financial position, there's a lot that we can improve on. And I still want to take this time just to give everyone thank you for all the work that you're doing inside the walls of the hospital, outside of our community, doing the fundraisers that you were doing the last few weeks of just bringing joy to how many families, Jen? How many families were it for the farm trip? 350 kids. 350 kids. Just amazing work to not only do all the work that you're doing within the walls of the hospital, but like Marcus said, for Steve to go above and beyond and be a part of the community and in various fashions. Just thank you for all your work that you've been doing this last year, and really means a lot to everybody that cares a lot for this hospital. The other thing that I wanted to mention is like my fellow director, Director Pimentel said, I was at the Board of Supervisors meeting yesterday, and I just wanted to thank publicly, put it into the record for the Board of Supervisors. They passed a motion yesterday at their meeting to approve their board chair, who's our local representative, Felipe Hernandez, to send a letter to our state legislature, our partners at the state legislature, and also at HCI as well, to please don't forget about us, about Watsonville Community Hospital and the healthcare district when it comes to the rural health transformation fund that's coming down from CMS. That's potentially between $100 and $200 million for our hospital, and I know that we'll have an item in our healthcare district agenda that touches on this. But I just want to thank the County Board of Supervisors for continuing to advocate for us and our other partners in the local nonprofit sector, and then also our other cities across the county that I think are also going to follow suit. So just thank you to the Board of Supervisors and all of our partners for keeping us in mind and for understanding the importance that this hospital plays in the entire local healthcare system. With that, I'll close down comments from the board members and move us on to our consent calendar. We have two items tonight. One is a minutes approval for November 19th, for our meeting in November 19th, 2025. And then the second is our policies / policy summary approval for December 2025. Before I open up for public comment, any questions from the board on either of these two items? No. Okay. Seeing none, I'll open up to public comment. Anyone joining us online wishing to speak on any of these two items? Okay. Just saw two new people join online. Anyone wishing to speak on the two items on the consent calendar for the hospital meeting? Okay, seeing no hands raised, I'll bring it back in person. Okay, seeing no hands raised, I'll close down the public comment and entertain a appropriate motion for the board. Move to approval. Thank you. Can I get a second?
I'll second. Creel? Thank you. Directors Pimentel and Creel. I'll take roll on this item. Director Cox?
Yes.
Director Creel?
Yes.
Director Gallagher?
Yes.
Director Pimentel?
Yes.
And Chair Nunez?
Yes. Okay, I'll move us on to our discussion items for tonight. Our first item is the Medical Executive Committee's report approval for December 2025. It's a report that we just received in closed session. Any questions for staff about this report before I open it up to public comment? Okay, seeing none, I will now open up the public comment for item number 3 on the hospital agenda. Anyone online wishing to speak to the board about item number 3? Okay, seeing no hands raised. Anyone in person? Okay, I'll close down the public comment. I'll bring it back to the board for an appropriate motion on item number 3.
I'll move to approve.
Thank you. Can I get a second? Second.
Thank you. Directors Cox and Gallagher. I'll take roll on this item. Director Cox?
Yes.
Director Creel?
Yes.
Director Gallagher?
Yeah.
Director Pimentel?
Yes.
Chair Nunez?
Yes. Okay, we'll move on now to item number 4, the leadership report. I like that title change. Steve, whenever you're ready.
Yeah, thanks. And once Rosie gets it queued up, I'm actually going to let Trina start tonight. She's got some operational updates, and then I'll go next. But I just did want to say to Directors Pimentel and Nunez, thank you for the moments of gratitude. Really appreciate that. We've got a number of our leaders here in the room and a number of them online, and lots of grateful staff members that really appreciate the work that you all put into taking care of the fiduciary responsibilities of our hospital and the healthcare district. So thank you for everything you do as well. Trina.
All right, so first up tonight is our MRI update. We have completed all of the agenda items that CDPH asked us to complete. 3 of those are policies that are in your packets tonight that we're asking for final board approval. And we hope to hear from them soon in terms of when they will come out and do our site inspection. So that is it with that. Holiday Hope. Yes. Holiday Hope. Thank you to Jen and her team. Special shout out to Lydia and Emily, who were the champions of raising this additional $7,500 on top of the generous donation from medical staff. So thank you very much to all the individuals in raising the funds. We had 298 children show up on Saturday. We were able to give out $350 Target gift cards. And in addition to that, it was kind of a very welcoming surprise to everyone. The Toys for Tots teamed up with a future superhero. So we had, oh, what's his name again? I forget.
Deadpool.
Deadpool, thank you. Deadpool Santa show up. The kids were very excited about that. And they also teamed up, when Jen and her team showed up, there were tables set up with all kinds of extra toys that were there available for the children to pick out, on top of a table for cookie decorating. And we also had another person, Manny Marino, donate a photo booth. So it was really a fun time had by everyone, and this all went to our farm worker families in our community. So special thanks also to our Santa, Javier Ayala, and all the staff and community members that also contributed either by donations or their time setting up and tearing down. So another huge success. So thank you again, Jen, and to your crew and to everyone who participated. The other fun, exciting thing that happened is our inaugural ICN graduation. Dr. Alexander and Dogan put this on along with the labor and delivery and NICU staff. And a fun time was had by all. It was the inaugural, so we had about 10 families show up. It was about 30 people. And again, hoping to make it, even bigger next year. And thank you to Jen also for her generous donation. And there was also a donation from Stanford that helped provide funds for this event as well. Last but not least, this year, instead of doing a holiday party, we did a winter wonderland for staff and physicians. Again, thank you to NEC for their donation to helping us have extra food and all kinds of crafts and games that were developed and done. All that was put together by Cecilia and Melissa. Special shout out to you and all of the fund committee members, and also to Susan Sample. Lots of fun was had by everyone, and we had a lot of positive comments about this year's event. So thank you very much for that.
I think I'm up. Okay, thanks, Trina, for that. That's a lot of good stuff, and we wanted to make sure that we don't forget about those during challenging times. Wanted to present some data that I received from our friends at the Association of California Healthcare Districts. So you can see what other healthcare districts offer. I thought we've been so focused as a healthcare district on the hospital, and really all we've been able to do is focus on the sustainability of the hospital. And so it's important, as we've been having a lot of public conversations, community conversations about the state of the hospital and the state of the healthcare district. There is sort of a perception, I think, in the community that the hospital is the district and the district is the hospital. And that is not necessarily just the case and doesn't necessarily have to always be the case. So I thought it would be helpful to sort of see what others are doing. So there's 75 healthcare districts in California. We are one of them. And so these data are from ACHD. This is the breakdown of hospitals across healthcare districts in the state of California. So 44% own and operate their own hospital. 40% have no hospital, and 16% have a hospital that's leased or operated by another entity. So I thought this was interesting that it's pretty prevalent, but it's certainly not all. And there are sort of a wide variety of how those are done different. And some of these have changed just in the last couple of years, right? Whether they've lost a hospital or changed it to a lease or things like that. So if not hospital, then what else are people doing in healthcare districts? And so these are some of the most prevalent non-hospital services, grant programs, ambulance, skilled nursing facilities, and physical therapy being kind of the top three. Urgent care, hospice, behavioral health, rehab services, non-hospital pediatrics, respiratory therapy, primary care, pharmacy, imaging, cardiopulmonary. We do some of these things, right? We have a couple of these things within coastal healthcare. And others are part of that long-term vision of the healthcare district, right? Some of these are things that our community, the 93,000 people in this community that we serve, could benefit from more of, could benefit from having additional services. So it's just feel like it's important to understand where we could go in the future as our healthcare district evolves, as we get our hospital financially sustainable and can actually focus on other things. Hard to think about when we're in the midst of what we're challenged with the hospital currently and in the future, but always important to kind of think about what those next years, those further years out could potentially be. My next section, I guess I can stop and do questions, or maybe we want to wait till the end. Whatever, let's keep going. I'll keep going. This is a question that the board asked of us at the beginning of the year, is to identify and define ways that we can measure, specifically develop a system to begin reporting on the number of patients who require interpretation access. So this is, this group that is listed here, a number of those folks are here in the room and online. Thank you to those folks who have been working on this. I think we've gone, I think this group has gone a little bit above and beyond what the baseline board ask was, and I'm going to share with you some of the data that we have and some of the things that the group has done to try to improve interpreter services, and some of the things that we know we still have gaps in, and so some things to continue to work on in 26. You're not supposed to read these. I highlighted Watsonville Community Hospital. We're the 15th highest percentage of patients whose preferred language is not English out of 414 California hospitals. So 38% of our patients prefer a language other than English, compared to a state average of 14%. So that's why this is important, right? We're way up there on the left-hand side of this curve. So we've talked a lot about how our systems are challenged to measure a lot of things, right? We have state-of-the-art, necessarily non-optimal systems. So there are some things we can measure and pull reports on. And some of those are up here with respect to interpreter services. So patient counts by preferred language for discussing healthcare. I think that's important, is that it's asked about not just preferred language, but your preferred language for discussing healthcare. Some people really feel comfortable with English and Spanish in the general day-to-day lives, but if it's like getting into technicalities of healthcare, that's where it's really important to ask them about that so that they can give us their preference there. Percentage of patients by preferred language relative to the total department admissions, interpreter services, so how much we're actually utilizing our interpreter services. And then this last one, I'll show you a table on the average number of interpreter service engagements per patient length of stay. So if you would assume that if somebody's here longer, we're going to use the interpreter services more, right? And the data sort of shows that, it also sort of shows that we could do better. So some of the things we've done so far to improve this process and these data, standardizing the preferred language for discussing healthcare field to allow only a single selection. So before there were multiple selections and it was a bit challenging to interpret the data. So now it is a single selection. What is that preferred language for discussing healthcare? Added a dedicated admission assessment question. Does the patient need interpreter services? So that's kind of a second check on that. Implemented discharge flow sheets to specifically document interpreter services use during discharge to make sure that the patients and the families know what to do and how to care for their wound or their illness, their medications, et cetera, when they leave the hospital. And then adding interpreter service related questions in the historical section of the chart to be completed by the patient, to be completed at patient arrival in emergency departments. This is not just for inpatients, although the data I'm going to show you is just for inpatients because that's where we have most of the data so far. So first kind of just baseline demographic, and this gels and matches with the 38%. I think this number is about 36% of patients who have a non-English preference. So just preferred language of our adult inpatients over those 4 months. So the end of the year sample size. See, 2/3 or so are English and the rest are mostly Spanish, but also some others. And then the interpreter service usage for those adult patients. So we use Propio is our primary company that we use for the online phone interpreter services. We also identify in the chart if we used an approved hospital staff member who are certified as interpreters. Sometimes we use family members. That's not always the preferred method, but sometimes it works really well. And other ways that we are getting those services for patients. And then this is the one I mentioned before. So interpreter service usage by length of stay. So the number in each box indicates the average number of times interpreter services were documented as having been used for each patient for that language for the length of stay that's up in the blue. So a patient who was here for patients who were here for an average of for a 3-day length of stay, we averaged documenting having used interpreter services once. So that's probably where we have an opportunity for improvement. That person who was here for 3 days, we probably used it more than once, but didn't document it. Or B, maybe we didn't use it as many times as we should have and used other means or did other ways of communicating with the patient. And you can see that is pretty similar as you look across as the length of stay gets longer. The number of times we use interpreter services generally gets higher, but it's not at the point where it's once a day, multiple times a day, which you might expect. Correct. The non-English preferred language percentage is much higher in our labor and delivery population. And you can see the Mixteco language really pops up in this population. And we just had a really good conversation last night at MedExec about that and about some another Mixteco language interpretation service that's popped up in the community that we're going to work on and starting to tap into, so that we're reaching out to as of today. We know that that's a challenging gap. We do have, as of new this year, an organization in the community that does have Mixteco language interpretation services. They're primarily only available during the daytime hours. They would prefer a scheduled appointment. That doesn't always work because somebody comes in labor in the middle of the night. So we are continuing to seek out additional services for that. And again, these are overall utilizations for our, I think I forgot to change the heading on this one. This is our labor and delivery patients. Using Propio again, we have been able to get some Mixteco interpreters on our online service, but it's not always well available. So, yeah. Hopefully that's helpful, a good start, right? We've clearly got some work to do.
Yeah.
But I think I know the team here, thank you all for participating in that, being a part of that is really important. Okay, switching gears to, and really kind of a bit of a lead into Julie's presentation on cost and finances. We want to be able to continue to providing all of those services, right? Those services to all of our diverse community members. And we know that we need to ensure that we are optimized on the financial side. And we know that we're not, based on the finances that we have right now, based on the volumes that we have, payer mix that we have. So it's really imperative that we continue to look at every single cost that we have here and the services that we're providing and make sure that we're optimized. So some of the cost savings that we've realized so far in 2025, these are annualized compared to 24. Almost $1 million in management reductions so far. The managers who are still here feel that because it's more work. But we felt like this has been really important from an attrition standpoint as people have left. There have been some positions that we've replaced, but some that we have chosen not to replace. And that's saved us almost $1 million on the management side just in the last year. The pharmacy team has done a wonderful job helping us reduce our prices through the 340B program for our drugs and medications. So that's over 700,000 annualized. Travelers or our contracted labor staff members based on last year's financials compared to this year's, we're at about a $664,000 annualized savings. Supply chain contracts. So this isn't about what was spent. This is about what things cost based on our new supply chain director negotiating new rates and prices for our supplies. About a $358,000 savings annually that's found so far. And we have had to start looking at some services. So physical therapy outpatient. So this has not impacted inpatient physical therapy. Or speech therapy or anything like that, but outpatient physical therapy, we worked with our physical therapy rehab practice management team to identify that it was really not a full 5 days of full schedules that were happening. So they've kind of optimized it down to 4 days, and that's been able to save us a couple $100,000 annually. Based on those changes over the last few months. But we know that's not enough because we know what our finances continue to look like month over month. And so we need to continue to do diligence on our costs and need to continue to do due diligence on how much the services that we're providing are costing us. And so this is just total department cost annualized for this year. Roughly, these are costs that come out of our monthly department budget spreadsheets that go out each month to the managers so that they can look at how they're doing on their costs compared to budget. And I just took the first 10 months report and just annualized it over 12 months for actual total cost, just so you can see what we spend in each department. And then so all of our services help people, and we see from our finances we can't afford all of our services at this time, right? So we may need to do temporary consolidations in addition to that physical therapy that I mentioned earlier. Closures may be needed while we explore partnerships, right? So we're gonna have a partnership update later in the district meeting. We don't have a partnership presentation to a partnership proposal to bring at this time. So we kind of need to continue moving in two parallel paths. One is looking for and seeking a partnership, and the other is identifying the sustainability path for if we don't get a partnership. Right, and so that's part of this, and while we wait for QUAF decisions and some of the other unknowns. So one example that that we're looking at is the intensive care units, is the adult intensive care unit. We have an average of 1.4 patients per day over the last 13 months. Sometimes it's 3 or 4, sometimes it's 0. When there's 0, we still have some costs in that department. The 12-month revenue collections have been about 1.1 million, and the 12-month department expenses, as you saw on the last slide, have been about 3.75. So it's about a $2.6 million loss annual for that department. That's seen about 100 patients in the last year. All those 100 patients have been helped. That's really important. We want to respect that. Every single one of them has a story. And we might not be able to do all these things, right, if we want to sustain ourselves on our own. And so any department closure, service change is going to have to come here to the board. That's not what today is. It would be agendized and specifically, specific action item and ask. But this is really to start the conversation, to know that and to understand that we're looking at this and how we're looking at this, get feedback on it, and really go from there. But this is really our fiduciary responsibility to do that kind of analysis everywhere throughout the hospital to make sure that we can, while we probably can't keep every service going on our own, we want to be able to keep some services going on our own if we do end up staying on our own. That's an important part of what we're doing. So happy to take feedback and questions from the board on any and all of that.
Any questions for Steve about?
Back to the interpreter slides. It's way down the weeds, silly question. There are several categories that have multiple languages, English, Mixteco. Was it because the patients prefer both, or why?
I have to ask my wonderful data analyst Manisha this question, but instead, since she's not here, I will guess. Which I believe that was from before we locked the MedHost drop down to, so you can select one preferred language. Because before you could select multiple. That's where those data went.
Please, it's a comment, not a question. Steve, I clearly heard you said this is the beginning of a discussion.
Yeah.
At the beginning, I'd like to put in that ICU is kind of pivotal for the whole rest of the hospital, surgery, med-surg, et cetera, et cetera, et cetera. So hopefully that is taken into consideration.
Yeah, thanks. Yeah, it will not be a conversation and a question that does not include med staff and physician leadership and nursing leadership and so forth. So absolutely.
Go back, Rosie, to the,
I can do which one.
it's just the last slide of listing the costs, or one prior, sorry. Want to process this a little bit more.
Okay, if other directors ask questions.
Yeah.
Any other questions for Steve? Just mostly about this slide, and then I did have some questions, I think, about this conversation, and then a couple of previous ones as well. But
Let me ask, a bigger question. You gave the example of the intensive care unit. Realizing we're not deciding that, was that literally just an illustrative example, or is that kind of one, not recommending, but it'd be one of the first ones we look at, like, why pick that one out? I guess that's.
I didn't put the column on there because I didn't finish it, but if I were to sort of flesh this table out, the column to the right would be number of people helped, right? Number of patients served in each of, compared to each of those dollar amounts. And it's the smallest one, right?
Yeah.
It's expensive. It has a financial loss. It has a pretty clear break-even census in the ICU is over 4, and we're 1.4. And it's about 100 patients or so in the last year, 90 to 100, and that's those are. We've also got good partners in the community that have ICUs. Yep. Yeah, it's not a lot to get to other places. Not to say that it's easy, not to say that it's not, disruptive of lives and patients and services, and potentially, as as Director Gallagher says, other services as well. But we want to look at what's also available elsewhere and what, would be financially helpful and also least disruptive to the patient population.
Appreciate that context. Again, I'm acknowledging you're not recommending that, but it's illustrative of the hard decisions we have to take. We have to start having these conversations, so I'm really glad.
Yeah.
Again, it's weird for me to say this, like, we weren't elected to downsize, right? We were elected
Yeah,
with the ambition
hire me to do that. Yeah.
But this is the moment we're in, and we have to be clear and communicate well to our public, our stakeholders. This is what we're looking at, so I appreciate that we're having this conversation, even though the month isn't the best month to have conversations like this.
Right.
Let me ask in the neonatal, intensive care with 100 per year, was there ever a point in time, you get this Joe question, like, did we ever have 500 in our ICU? Like, is 100 or about the range of 100 to 150?
I don't know.
Yeah. Or if there's any historical perspective in the last 5-10 years on what the numbers have
The
been.
use of, I think overall, with our daily census being lower, et cetera, I could answer that yes, in the past, we had 10 or 15 more patients a day in the hospital. So were I a betting man, I would bet that ICU was busier in those days.
Instead of 1.4, it was certainly 2 or 3 or so. That's something.
Tony, Steve, could I ask in terms of looking at the analysis, say 100 patients help, rather than a mean or an average, look at a distribution of how often there were 2, 3, or 4, was that a standard deviation?
We have done that. I didn't present it as
Good enough.
as a means of sort of simplifying the conversation, the presentation, but we absolutely have that. Julie's done a nice job of percentage of days that were 0, 1, 2, et cetera. And we'll take that into account when we, as we move forward. So thanks for that.
Any other questions for Steve or for Trina?
Please stay in the big picture.
Yes.
Like, we should be dictating this, not be asking you this question. As a board, I think we own the fiduciary responsibility to say, by February, we need to have a plan to do X, Y, Z. I guess I'm just acknowledging as a board, we need to play a clear role in articulating, is our expectation that by February, we have to pick units that save us $5 million a year. I'm just acknowledging, like, we need to work and give direction to the CEO and staff about what our expectations are, while also asking the CEO what their recommendation is and what staff. So my question is, I'm kind of a hybrid between, like, in my staff role, I would look to the board for guidance, what their expectation is, when we want to, what's the size of reductions we wanted by when. And then as staff, looking for advice on what are
At least harmful.
Yeah.
At least hurtful.
Yeah.
Yeah.
I'm stumbling with my words, but I'm just acknowledging it's our role to provide our CEO and staff with what we're doing, not just say, tell us what to do next.
I agree with that. I would love to see more, as it progresses and if we have to make a decision at some point, I'd love to have more information about all of, just more details in order to help support the staff as they make these, as these things move forward. I know that we're in a really critical position financially right now. And nobody wants to make cuts ever. So I'd like to know as much as possible before that decision if that decision has to be made.
Yeah.
I know there's no plan to make that right now.
Right. Any other questions? I have a couple. I'd kind of stay in this discussion, I think, and then I could ask questions of the other ones, but Steve, my questions and I guess just direction for the staff, and which I don't know, maybe, our legal counsel can ask if I can give direction in this. It's just a general report, but more of a question of, I would imagine that it is different for every one of these departments of how long it would take us to close one down, right? And where we would realize some of those savings of actually closing it down. And so I don't know when the right time would be to bring it back for a more thorough discussion, but to have that data, those figures, as well as like X number of months or whatever, a couple of quarters to close this service line down. And then is it going to happen? Will we see the savings in time for it to even make a difference, right? And so I think that that's essential. And then I think from both of my fellow directors' perspectives, and then also Director Friel as well, just what the process would look like for us to say, yes, please go do this. And then for us to have a first look at all of the data for all of these different departments and then say, okay, this is what we're thinking. Please think about giving us a couple of different roads to go down. And then to have real thoughtful conversations with our staff about, this is what we're thinking about, option A, B, or C, or whatever it might be, right? I just don't know what the right mix of public communication, staff communication, internal communication would be as we're going through this process. But I think that that's critical as we start to move and think about these things. And I do want to echo, what she said and what our fellow director, Pimentel, said is, we think, and we'll have an update, for the external partnerships, later today or the Pajaro Valley Healthcare District Board will have an update on it. We feel that we deserve some of the additional dollars that are coming into the state of California through the federal government. We also feel that we deserve and have earned the money that comes in through the fall program. And some of those things are going to offset a majority of the losses of which we had this year. We're also banking on things that have not already happened. If we go into 26 and 27, thinking that we have these dollars coming in and they don't eventually come in, and none of those three things are guaranteed. And so I want to echo what you said, Steve, and then also Director Pimentel, that goal number one of when this board was established and when this hospital was brought out of bankruptcy was to ensure that the hospital never got back into that position. And so I think we need to have these conversations as a board. And part of that conversation is having that conversation with our staff, having our conversation with our physicians, and having our conversation with the community about this is the path, or these are the paths that are in front of us, and how do we walk down them together, right? For the good of the community, good of the hospital, all those things. And I just want to say to the rest of the board, we are trying as hard as we can to turn this around, right? We are trying as hard as we can to make sure that these are conversations and we have a plan in the case that some of the things that we're doing don't work out. But we need to really go through these sort of conversations thoughtfully and with enough time so that it does not feel like we are ripping off a Band-Aid, but instead having a thorough conversation with staff about this. So just my overall comments, and I suppose a kind of direction and question there, Steve. And obviously we'll have additional conversations about this as we move forward. And Julie will have a report for us for the budget in a few moments as well. And a couple other questions. Along with the closing of what one of these services could look like of people impacted, I'd also like staff impacted. I imagine we have that as well. So just number of people who are part of that department, what would that look like? What sort of, institutional knowledge are we gonna lose if we decide to close this down, and what that means overall for the team? I think that's important. And just appreciation for you bringing this to us at this moment, right? Where we have some time to actually have these conversations, think these things through, and then do it in a way that I feel like at least pulls everybody's input as we make these really difficult decisions. I have a couple more questions about some questions about the interpretation services. So can we go back to the length of stay and then where we have like the one-time use? I think that was really interesting to me. So just so I'm understanding this, so they were in the 1 through 8 is the number of days that they were in for their length of stay, or am I reading that correctly?
Yeah, the blue number is the number of midnights that they stayed.
Okay. And then the number of times that they accessed or asked or used the interpretation service?
Yeah.
And is that the interpretation service, all of the different options, or is that, oh, interesting, okay. Because I was thinking the day length of stay, with the one-time use, I was thinking that was just with the use of like the propio mechanic, and that wasn't taking into account the use of like interpretation with a family member? Because
So it probably
Yeah.
is because we're probably not good at documenting in the record that we used a family member.
Right.
That we used
Mhm.
staff, bilingual staff members certified.
Right.
That's probably a lot of what's happening is that we're doing it, we're communicating with people, and we're not always doing the documentation of that particular piece of it.
Yeah.
And, interpretation services with a family member can be more comfortable for a lot of people, and it can also pose challenges clinically if that family member has trouble
Yeah.
translating medical terminology and things like that a professional medical interpreter could do.
Right. I only say that because go ahead, Trina, I'm sorry.
That's okay. I just wanted to also add, I think there was a little confusion about that needed some more clear definition in terms of whether interpretive services were used. So if you have a patient that's Spanish speaking and the staff member Spanish speaking, people weren't interpreting that as
Right.
needing an interpreter because they both spoke the same language. So I think that's why the numbers are even more skewed because or don't really reflect maybe what is really accurate, because I think there was that definition there. And so
Right.
we're trying to define that more closely.
Yeah, and just making sure that from a regulatory standpoint, we're documenting it
Yes.
appropriately, right? Because the Joint Commission is English centric, right? So they see a
nice way to put it.
patient who was primarily Spanish speaking, and they see, no documentation of translation services. They assume that we didn't talk to the patient, but really we have bilingual staff that we're talking to the whole time. We just didn't document that. Right. Not to say that we do that every time, but I think that's what happens a lot. If that's what you're getting at.
Yeah, I thought there are a couple of things that, so in that's what I was thinking as well, why it was one or less or fewer, I guess, in the first 3 days that they're using it once. And then I've been in that situation myself where I was there with a loved one and I was at the age of 12, the interpreter, like that sort of situation. Like that's the reality for our community, right? That's what our community is. That's who our community is. And then to your point, Trina, it's not interpretation services for the staff. That's their first language as well too, right? Like that. And so this is a fantastic start. Steve, just thank you. I know this was one of your goals, but you did an incredible job and the staff did a great job of getting us data to actually look at and to actually make some interpretations from. So this is awesome. This is exactly what I hope the board was looking for when we were thinking about this, right? Like this sort of language equity. Yeah, this is great. And then a couple more questions. I apologize for dominating the time here, but I'm wondering if you can like how thorough you can pull data on the other healthcare districts that are doing urgent care, skilled nursing facilities, and then also ambulance services? Like, what do their systems look like? What, obviously I don't know what they're reporting to their board looks like in terms of revenue. It's probably
Yeah.
not as transparent as ours, I would imagine.
I did, yeah, they're not. I did a little bit of that
Yeah.
with ambulance, because that was
Right.
something that somebody in the community during a community meeting, they're like, oh, and we could have our own ambulance, oh, cool. So I just tried to look at some of the, what are there, 7 or 8 different districts that have ambulance service. I think I found one that had ambulance service specific data and particularly finances.
Right, yeah.
It was actually a loss, so
That's
that was
really interesting.
disappointing.
Okay.
But I need to learn more about that, because I know that there are supplemental, you know, reimbursements for districts for transporting Medi-Cal patients. But I think if there were a service that we were like, yeah, this would make sense for our community, this would fill a community need, being part of that
Right.
association would allow me to go to each of those individual districts and
Mhm.
talk to their
Talk to their
CEOs and get their data and their business plans and whatever else. We're all very sherry over there.
Yeah, I would hope so.
Yeah.
Yeah, that would be fantastic. I know, skilled nursing facilities are extremely difficult to run, but they also generate revenue, right? Because there's and then the urgent care, I think that some of the challenges in our emergency room, just the use of it, what that would look like to even start thinking about developing a potential urgent care, whether it be on I don't want to get into too much of like having a conversation and stuff that's not agendized, but just interesting things that you brought up. So just thank you for that part of the report. I think that's helpful for us. We're going through it. I do want to take public comment on this. Any other questions for staff before I open up to public comments? Okay, so I will open up public comment on item number 4, the leadership report. Are there any raised hands online wishing to speak on this item?
No hands online.
Anyone in public wishing to speak on this item? Okay, seeing none, I will close down the public comment for item number 4. Thank you, Steve. Thank you, Trina. And I'll move us on to item number 5, the Chief Financial Officer, Monthly Finance update.
Okay, just as a reminder, with our shorter months in between, we are actually reporting on the October close. We will be reporting at our January meeting. We'll really be back on track and reporting November and December. I can already tell you, we just closed November and it was a very similar month to every month you've seen here, with about a $2.5 million loss. So I'll just save you the waiting for that information. First slide up. Okay, so, in the month of October, we did have a slightly better census. Length of stay was up a little bit. Case mix was up a little bit. But we're not meeting our volumes that we had budgeted for. And as we've talked about all year, a lot of our budget was based on some things that we were going to try and get in place. And early on in the year, we decided to put a pause on them, or they were not ready, or they just haven't materialized the way we planned. And you'll note when we do go to the budget conversation later, how we've tried to mitigate that from happening again for 26. So there's a lot of things that in the budget didn't materialize, and that you can definitely see it both in the month to date and year to date when we look at the net operating revenue. It's the same story all month or all year, which has really been, we haven't had the volumes that we projected there. Just for the month, our admissions, we were down about 50 admissions from what we had budgeted, which is like 17% of the budget. And we were a few hundred down on outpatient visits, which was like another 13%. Probably the good news in October was that both our deliveries and our surgeries were fairly close to budget. Let's go to the next slide. So you know, on a year-to-date basis, it's been very painful to be, you know, almost $29 million below what we had budgeted for revenue. That's pretty much impossible to live on. We have made some headway on the expenses, as would be expected when you don't have the whole volume, but $8.5 million favorable to budget doesn't account for the whole shortfall. We've certainly talked here before that it's very difficult with the low volumes that we have to reduce staffing, which is our largest expense at any clip near what we don't have in volume. You can see that we've made some good progress on supplies, not only in the things that Steve talked about, but just in general kind of supply usage. And some of that is, you know, having fewer patients. Some of that has, you know, honestly been our cash crunch, and that we have really had to pare down supplies and really get pretty nimble on what do we need this week, next week, as opposed to past lives when you just have a certain amount always on the shelf. Let's go to the next slide. So this month I wanted to take a little bit different look. And so, you know, one of the things, there's a few things that really impact the cost of care. Case mix, or the acuity of a patient, impacts care. And so if a patient is sicker, they often utilize more resources. We have a slight increase in our acuity this year. It's not a significant increase, but every little bit does potentially add to the cost of care. We also have what was called an outpatient adjustment factor, and really that helps us normalize that inpatients are more resource intensive generally than outpatients are. There can be, you know, some variation in there, and that as what we've seen this year is we've seen a real decline in the inpatient volume, and still generally fairly strong outpatient volumes. So this outpatient adjustment factor has shifted a bit, but it allows us, by using that, and when I say how I use it is in like an adjusted patient day, it's a metric that we use to quantify and compare period over period, or compare ourselves to some other measure. It allows us to just take into account how those shifts also play a part. And so took a moment just to compare October year to date with last October year to date, so 24 versus 25, to see how we had done, because, you know, every month looking at, there's another $3 million shortfall in net revenue. It doesn't tell us as much about the story. You can see here that, and I'm going to kind of focus on the bottom half here. The top half is really, these are the numbers from those year-to-date periods. And the bottom half is what I'll call a per CMI adjusted discharge. So it's taking into account the case mix or the acuity of our inpatients. It's taking into account how we've had a shift between inpatient and outpatient volumes. And it's saying, okay, net operating revenue. Last year, my net revenue was $10,813 per CMI adjusted discharge. This year, it's only been $9,054. So some of that 16%, you know, some of that is explainable through the shift in the types of services, because again, you know, we've had fewer inpatient services that are going to generally drive that number up. A couple of numbers that I really wanted to point out was labor, because I've talked a lot here about the fact that we just can't flex down, you know, as fast as the volume has gone away. But this shows you that we are making strong work in terms of trying to control labor costs. I think we're always looking and begging the nursing team and the ancillary team, like, what else can you know, where else can you tighten up? Is there anything that, you know, we can be tighter flexing? But really what this says is we're only up 2.5% year over year, and we know we've had labor contract increases. And so they're right within that range of dollars. You can see that I'm going to come back to pro fees here in a minute, but you can see that the supply expense has, a lot has dropped off in the supply expense with a 12% decline. I think the other big one that stands out here is the pro fees, and this has been a year of a lot of pro fee increases. We've had the change in hospitalist groups, the change in radiology groups, kind of the additional expenses of having interim programs in place for a number of months during those periods of time. And we've had, physicians that have, come to us and said, we've been working here for a long time without an increase. They're basically coming saying, we need some increases, to be able to keep supporting call panels, things like that. So that is, really a big factor in this year's financials when you just look at it on this sort of a basis. Next slide. I kind of just talked through this a bit in terms of highlighting the big ones. I think what else I would say here is just, I talked a little bit about that inpatient versus outpatient shift, and really this first bullet point is kind of the other hard part of having that sort of shift. I mean, we are still serving the community, very strongly on the outpatient side, but in general, outpatient services reimburse about 50 to 60% of what an inpatient. So an inpatient admission is typically going to bring me a higher level of reimbursement than an outpatient. We see that, and we do a lot of analysis at the payer level, inpatient versus outpatient in terms of what our payer contracts and our governmental reimbursement looks like, and that's just kind of a fact of our business here. Let's go on to the next slide. So getting back to the normal, what did the stats look like? And I touched on this a little bit before, but admissions, we were down 54. Patient days, we were down slightly, but you can see that our length of stay at 3.67 was generally higher than most of the year. It's been 3.3 to 3.4 range. Our average daily census this month was 30, and we've had a lot of months where we've been in the 27 to 28 range. And then the case mix was up here. This is the case mix, and without the OB volume, which can kind of drag it down, but this is saying, the intensity of the patients that were in med-surg, tele, and when we have them in ICU. Strong points for the month, the deliveries were basically on budget, just a few short of budget. The inpatient surgeries actually exceeded, and the outpatient surgeries were right on budget, and 500 less visits on the outpatient side, and then a good portion of that was in the emergency room itself. Slide. So not much different than what we've been seeing year to date. You can see that, almost down 15% in our admissions year to date. As an overall ADC, we're running 29.4, so just shy of that 30 that we had this month. And our case mix isn't quite where we budgeted it, but it is up a bit from where we were at this time last year. Deliveries, surgery, and inpatient surgery is pretty strong. Outpatient surgeries are really a good portion of the variance there. What I've been reporting out each month, the cath lab volume that hasn't been there, the loss of a couple of surgeons where we've gone for months without surgeons, and thankfully they're now coming on board. So we now have our new orthopedic surgeon, and we have our general surgeon coming in January. And probably if I had to say anything that was the most surprising this year, it probably would have been that the ED visits were down by almost 8%. You know, I'm sure those working in the ED, it probably doesn't feel like that on most days with the 12-bed ED, but we are actually below what we had budgeted. And I think last year, if I remember correctly, you know, we had budgeted for a 1 to 2% increase because that's what we were seeing all of last year. Next slide. Okay, so did a couple of new graphs this time, a little bit different, not too drastically different, but here the blue bars are your acute admissions and the orange line is your patient days. And since we generally run a length of stay in that, you know, 3.3 to 3.6 range, most of the time they're going to follow the admissions pretty well. You're going to have, you know, a few outlier cases, and for us, you know, 2 or 3 outlier cases in a month can really drive where you see a bit of a gap. But you know, there's not that much significant gaps here. And I just showed you kind of along the bottom, you know, how the length of stay has been pretty consistent. Next slide. Here was our delivery slide. Shown you this before. We've had pretty strong months. What I added at the bottom this time was just our NICU admissions. That has been a spot this year where we've had some months with some pretty high NICU admissions. The last one was in August when we had 20. But you know, a lot of the other months we average in the 6 to 10 range. So you know that if you think about the overall deliveries being 60 to 70 and having 6 to 10 NICU admissions, that you know says something about our program utilization. Next slide. On the ER and non-ER visits, in the top graph there, the orange is the non-ER visits and the blue is the ER visits. So ER, I mean, it's down a bit this year, but it's relatively flat month over month. Outpatient visits have had a little bit more of a volatility. I mean, it's still kind of grown. If you had a trended line in here, it'd still be a bit of an upward growth. But it is where we are doing some of this analysis on where do we have the volume? Are we as efficient with the hours that we're open as we can be? And this is also where we can sometimes be subject to being without a service, either due to an equipment failure or a staffing failure, such as our loss of the MRI volume over the last few months. And then the bottom slide was just our ER visits, and you know, you can see the last 4 months or so they've been you know, fairly consistent. But it's interesting how the ER visits per day looks like it spikes in September, even though there's really, it's you know, somewhat the factor of having one less business day in the month of September. But the oh, actually I said that backwards because that's the blue line is the ER visits per day. What the orange line is saying is what percentage of those actually converted to an inpatient. And so that's not just pure ER visits, but the fact that, you know, we run somewhere between 6 and 7% of our ER visits converting to an inpatient. Really what that speaks to is the acuity of those patients that come in through our ER is a lot of times not that high. They don't warrant the need for an inpatient stay. We also have a very strong case management team that does very good reviews before they get admitted as an inpatient, because if they're admitted without the proper medical necessity, we're not going to get paid for that admission. Next slide. Here's a quick look at surgical cases, and this time I just kind of tried to pull in the top volume specialties. They've been pretty consistent throughout the year. It's our OBGYN cases, general surgeries, GIs. Those tend to make up the inpatient top three. And on the outpatient, I did top 5 here, but the general surgery, ortho, OBGYN, podiatry, and ear, nose, and throat. And, this is even with, having some loss of physicians in the general surgery and ortho, they did still tend to make the top 5. Next slide. Going back to a slide you're pretty familiar with our payer mix. On the inpatient side, last month had been, or the September month had been relatively low on the commercial. We did have some bounce back here up to about 15% commercial. Not our highest commercial month, but at least back in a place that tends to help us a little bit financially. Medicare was down this month at just under 27%, and we were at about 45% in the managed Medi-Cal. On the outpatient side, 23% for the commercial. So the outpatient is generally very consistent month over month, as you can see from this graph. About 46% for the managed Medi-Cal, 19.5% for Medicare. And I think, the bullet that I just made on the bottom again this is that consequence of having, higher government payers is just that they just don't pay at the same level of commercial. And it's really, significant when it's 50 to 70% less reimbursement for the, same sorts of services that a commercial patient might get. And with that was my last slide, so I can take some questions.
Any questions for Julie before I open up the public comments? Okay. I do want to open up the public comment on item number 5. So we'll go out to folks joining us online first. Anyone wishing to speak on this report?
No hands on mine.
Okay. Anyone in the public wish to speak on this report? Seeing none, I'll close down the public comment and I'll kick it right back to Julie for item number 6, the Healthcare District Consolidated Budget Approval for 2026.
All right, so moving over to the budget. I think before I get started here, I would like to just do a special acknowledgement to somebody who's in the audience, Vanessa Chu back there. Vanessa is our Director of Finance, Planning and Analysis, and she has been the lead person running our budget this year. And that is no easy feat because we do our budgets in Excel. They're very detailed. Trying to get information is a lot of detail and digging. Trying to put it together, keep it all in sync. There's just an incredible amount of work that's gone into this budget. I will make some comments about our conservatism and things in a minute, but I just really want to say it's, generally speaking, it's Vanessa and our senior financial analyst, Dina, who are responsible for so much work here. And then, thank you to the directors and leaders as they have provided input. Every year, I swear we promise them that they're going to get more chances to see this and provide input. And it gets so crunched and so hard to do, but we are very thankful to them. And I know that these guys made a ton of efforts to just do as much as they could on this budget this year. So with that, we will take a look. This is not super easy to read, but I'm going to highlight, a few of the points. First of all, we are budgeting a loss for the year. You come all the way to the far right, the last number, it says -7 million. That's a -7 million loss budgeted. The way we put our budget together, we looked at what 25 annualized look like. But we take a point in time when we annualize that. But this was about September, October timeframe where we said, you know, we're on track and probably likely to lose almost $22 million. So as bad as $7 million loss sounds, going from 22 to 7 is a pretty big leap. We then build our base budget, which is generally the services we offer now, the things that we have now, kind of the way we operate now. It's before we layer on any initiatives. And initiatives can go in both directions. We generally are looking for the initiatives that are going to make this better and not worse. But sometimes, you know, we've had initiatives that just say, we know we've got to do this and it adds costs. So then we will spend a little bit of time taking you through a little bit more detail on the initiatives, and then the base plus the initiatives equals the 26 budget. Just taking you through a few of these line items here. From a gross patient revenue, it almost looks flat. We do some CDM increases through the year, or at the beginning of each year to adjust charges. We do a lot of analysis around that. But sometimes those adjustments can also reflect where we have brought charges down because we need to be competitive with folks around us, or because we saw that we just have a charge that doesn't make sense. We're not going to get paid at that level. Why is that charge, you know, where it's at? So, you know, we're going from, you know, about $1.062 billion to $1.065 billion in the gross. The gross number, you know, at the end of the day doesn't really mean a lot because we have so many contractual deductions from the government payers as well as even our own, you know, commercial payers. And then we have, you know, our provision for bad debt. We have, you know, in the last year brought in a bad debt vendor that's helping us do some collections on accounts that have kind of gone all the way through the collection process and don't, you know, haven't been reimbursed. We have that last kind of ditch effort to see if there's the potential of collecting with that secondary vendor. We started that process about, it was about, really kind of got going about mid-year. And so kind of see that they are able to collect some dollars. It's not huge dollars, but in our point, you know, every little bit helps. And they've, you know, this year been able to collect about $200,000 or a couple $100,000, I believe. So really where that leaves us before we factor in QAF and DISH money and intergovernmental transfers is it leaves us, you know, almost relatively flat, even down a little bit from what our annualized collectible revenue is for this year. And I'll get into that a little bit too later, because there were some areas where we continued to be very conservative on the volumes and even suggest a little bit further volume decline. Probably one of the biggest points on this that is still an unknown for us, and we're kind of putting out there our best estimate, is QAF 9. We do these hospital quality assurance fee programs. We're currently in QAF 8. It's got some more payments running through 2026, and then that program ends. QAF 9 is the program that has been in the approval process for the last, you know, I don't know, 3+ months or so. Originally, there was hope that it would be approved by the end of this year. Then the government had a 42-day shutdown, and we pretty much were assured that it wasn't going to be approved by the end of this year. Probably the bigger question is not whether, you know, when it'll be approved, but will it be approved in its current state as it was modeled? Will it be reduced? Will it be done away with? I mean, if there's any possibilities, there was a lot of questions that are not completely clear from the passage of HR 1. But they're, you know, the way we kind of read the tea leaves, you know, we get information from our, we use a consultant that helps us with QuAF, as well as, you know, CHA and other kind of industry experts that study these things in detail. You know, we believe that there is a QuAF 9. It's not that it's going to be completely taken away. It could be no better than the QuAF 8 level, or it could be better. The original model program was almost twice, we would receive twice as much as QuAF 8. It was about a $17 million pickup. But there have been conversations about maybe it would revert back to QuAF 8 levels. That's a hard one to even know what that means, because QuAF 8 was a 2-year program and QuAF 9 was a 1-year program. So, you know, there you can be doing a lot of guessing on what that really means. What we did for this budget is we assumed that the QuAF 9 program was going to stick, but we were only going to budget for 75% realization. We were not going to put the whole 100% in there. So we did budget additional dollars, which is, if you could read this, which I'm sure is pretty hard, but it's saying that with the remainder of the QuAF 8 program that still has payouts in QuAF in 26 and the new QuAF 9 program, there's a significant uptick in budget from $18 million to almost $44 million that could be received. So you could see this could be a tremendous boost for us if it plays out the way we're budgeting. And you know, it will be tough if it's not there. I mean, it will make it is what makes a lot of that change from almost a $22 million $22 million a year loss to a $7 million a year loss. We also have been working and are into some new programs for intergovernmental transfers, where we send money up and then we get more money back. And so we've got, those are some new programs. There's 2 programs for us that we are in for 26. So there's some additional expense there, but there's additional revenues. And I have a little bit more on that in the initiative slide. And then probably the one other note on other revenue is you'll see that our other revenue has dropped by about $1.4 million. And part of other revenue doesn't always mean more cash coming in the door. Sometimes it's just a revenue recognition. And so over these last years, as we've been having loan forgiveness for things, or we've paid off the loan to the Packard Foundation for the pledges that helped save the hospital back in 2022. As those events happen, you take revenue recognition. Those events aren't going to repeat in 26. And so we aren't budgeting of the things that bring in cash. We're not necessarily budgeting less of those, but we are budgeting less revenue recognition. On the expense side, the expenses are, a lot of them are driven by where we expect inflationary factors. Anytime we've budgeted for something that is like a new savings or something, you'll see that in our initiatives. So most of our expenses are based on, we know that there's an inflationary factor coming, such as especially in our benefits. We know that we have on the labor side, we have some contractual increases that are coming, but we also have taken into account volume. And so for the places where we are budgeting reduced volume, it can actually look like, well, gee, your year-over-year expenses aren't changing that much. It's because kind of volume decline is offsetting inflationary increases. And then before I go on to the initiative slide, I'll just say, from a down kind of below the EBITDA line is that we have factored in some depreciation because we do have new equipment that's coming online in 2026. The first big exciting ones are the MRI and the CT. And then we've got some new ED monitors that are coming for the ED. We've got some new labor and delivery beds and other things for the labor and delivery. So these things have been funded with Measure N dollars, with a Alliance grant that we got this year, sometimes just with other money that June has been raising in the Philanthropy Foundation. So we have started to put some more depreciation because as soon as those items come online, we will start depreciating those. So let's go to the next slide. So this kind of talks a little bit about the initiatives, and I will just kind of tell you up front, we were very conservative in our initiatives budget because this is where you have a lot of hopes and you have a lot of sometimes unknowns about exact timing or exact assumptions. And this was probably one of the things that got us a lot in the 25 budget is for as much analysis as we did, our initiatives were pretty aggressive. So this year we kind of took a reverse approach there. On the CT and MRI growth, there's a lot of the CT and MRI volume that is just part of the base. It's already there. It's expected to continue. Some of it has had its downturns with us being without an MRI for a couple months. It'll have to kind of regenerate itself. But it's not in these initiatives. This is kind of the incremental MRI and CT growth. And we, talked with Nellie about her expectations. We looked at, what's kind of our scheduling capacity and our utilization now, and what is conservatively expected. All realizing that if we just had all kinds of energy and resources to put into marketing and outreach, this numbers could probably be stronger. But this is conservatively, what do we think we have the bandwidth and the ability to do? So with that, our EBITDA numbers for these are fairly small. It's a couple $100,000. We do feel like there's a lot of the ability to absorb this level of volume without adding extra staffing. Pretty much, we're these don't require a lot of supplies. The biggest expense, as you would see here, is the depreciation and amortization, which is not cash going out the door, but it is recognized as expense. Then we have our 340B program. Jennifer has just been working her tail off this year on this program and getting all the pieces in place, getting all the data as clean and accurate and understood as possible. And she's at the point of recognizing at least $10,000 a week of savings over where we were previously running. And so that's really, this is based on, that $10,000 a week. It would get us $520,000 a year. And as we continue to get solid on this program and what it takes to maintain a program, these numbers could go up. But again, we're being conservative this year. Cath Lab is a place that we're kind of evaluating, Cath Lab Cardiac Services. What should this look like? And so we haven't budgeted volume in here. We don't exactly know what that is going to look like, what the timing is going to look like. And it's been a bit of we've tried to look at what if we budgeted some volume, and are we really ready to commit to that? Do we have the physicians in place for that? Will we have the demand? So, this is a budget just to say we need some staffing in here. We have an existing contractor who's been a big part of getting the Cath Lab ready to run. And we have the lease costs that we are already committed to. So those, this is, right now, we're just showing cost here. It's not that we're giving up on the program. We're trying to build what that program or the best use for the cath lab needs to look like. So that's what you see there. The supply savings, this is, we have a lot of work to do in supplies. Our new director has, just come in and rolled up his sleeves, and he's looking at a lot of things with tier optimization, par level optimization, fighting fires daily where we have supply needs, and trying to have good communications about when they're coming, when they're not coming, how quickly are they needed. Plays a lot of interface with AP on, making sure we're doing just-in-time paying so we can get just-in-time supplies. So this is really, there's a lot of process work there. This is kind of his conservative estimate of what he thinks we can get. There's definitely more savings to be had there, but this again could be a bandwidth challenge, and sometimes just needing to get the proper processes and things in place so that we can realize those savings. On the revenue cycle, Mike, our revenue cycle director, has done, he's done a lot of deep dives into where we have some opportunities, and he's actually got a list of, probably 8 or so different types of things, some being, mostly being cash generation, which you see here. Sometimes they're cash acceleration, just getting the cash in the door faster. We have some opportunities with where we're seeing underpayments or aged AR that's lingering out there a little too long, and then you potentially kind of lose the opportunity to collect on it. We always look at our kind of clinical documentation improvement and the ability to, code to the level of care we're giving versus having to code to a lower level of care because the documentation is incomplete. We're looking at denials and appeals and that whole process. So there's a lot of work here. He actually did kind of a high, medium, low, medium, high range. And we kind of picked that middle slot of what's kind of in the middle. So this, still, again, is with everything, it's do we have the resources and the bandwidth to do everything? So the total here, really says it's about a $2.2 million pickup on EBITDA if all of these things play out the way we've described them. After some depreciation and amortization for the CT and MRI, it's just shy of a $1.9 million improvement to the budget from, we would have been at an almost $9 million loss, and instead we'll be closer to a $7 million loss. Let's go to the next slide. I'm not going to spend too much time on this. We did, just so you know, we do budget by entity. The bulk of the work is really at the hospital level. That's where the bulk of the details are. The CHP group, which typically your medical groups will need to be subsidized by the hospital, as ours are. Some conservative estimates in here with bringing on some new physicians and allowing them time to ramp up in both the ortho and the general surgery space. And then we have one physician who's actually retiring. And then on the third column, which is the district itself, there's not a lot of expense here. This is where some of that intergovernmental transfer money, when we set up these new intergovernmental transfers, we have to work very carefully on, is it coming in through the district? Is it coming back to the hospital? Ultimately, we kind of consolidate everything and have the ability to use money to support the care in the hospital. But from an accounting standpoint, we have to get things into the right buckets. Next slide. I've probably talked through some of these, but I'll just quickly recap some of our base budget assumptions. Our overall charge master increase was 2%. It was made up of increases and decreases, and it was looked at. Often when you do these things, you try to look at for where is it gonna make a difference? You know, governmental payers that pay by the DRG aren't going to necessarily pay you more if you raise, you know, your room and board rates, you know. We also, though, do look at, well, how do our room and board rates compare to Dominicans or Salinas Valleys or Natividades? So there's that kind of comparative nature of the CDM increase. We did negotiate some of our major payer contracts this year, and so the you know, the impacts that we expect to feel from there are kind of tried to factor in terms of how we assign overall expected reimbursement. We talked about that we did co-op at 75%. That's both from what we pay in as well as what we expect to get back. Our new intergovernmental transfer dollars for this year will net about $2.4 million. That's after we pay up expenses, we get money back. We have used a consultant that's helped us get that program in place, which was, you know, is a fairly heavy lift when you're first trying to get into these programs. Most of our inflationary factors were between 3% and 7%. Really, where the variation is typically the different types of supply categories that we have. Big increases in the pro fees, and our largest increase was actually in our health care benefits, which is everybody's seeing that. You hear it pretty much on the news all the time, and even being a part of a big group, the you know, the Alliant group that we're a part of with other governmental agencies, everybody's seeing 14% this year. Next slide. You've seen this slide before, so I'm not going to spend a lot of time on it. This was just kind of where our volumes are. And I'm just pointing out that we did project lower admissions, which results in lower patient days and a lower census. Pretty much the same length of stay and case mix. Deliveries is getting a slight uptick because that's, you know, kind of been the pattern we've been seeing this year. We are predicting a bit of a decline in the ED visits and generally surgeries with a little bit of an uptick. Next slide. One of the ways that we try to sniff test our budget is with some, you know, hospital KPIs. So we look at a lot of things on a per adjusted patient day basis and say, you know, how is our revenue looking on a per adjusted day basis? What's the bad debt as a percent of revenue looking like? And we do the same thing with expenses. And, you know, it's really to ask ourselves, like, does this seem to make sense given what we know about the details belowhand? And you know, we feel like the first time we looked at some of these, we said, oh, you know, better go in, dig in a little bit deeper. So kind of throughout the budget process, we try to look at these things and helps drive where we dig into things. And so this is what the current budget looks like, which, you know, generally feels conservative, but realistic. Next slide. And this is my last slide. I know I've been doing a lot of talking and probably have some questions, but you know, our goal here is to have you approve our 26 budget. We then have kind of the finalization of the detail work, which is getting this spread as a monthly budget loaded into Meadows so that departments can get their monthly financial reports, and we update our own reporting packages so that they have the latest and greatest budget. And you know, then we distribute this to everybody, including our external partners. And I just want to kind of close out there. There's another reason for kind of the conservatism in our budget is because as we work with external partners such as West County Bank, we have reporting covenants, and this year not meeting our budget by as much as we had, we we tend to violate those covenants, and then we work with the bank to rectify it and get a waiver to that violation. But, you know, it's an extra step that we want, since those, funds are guaranteed by community partners, we want them to have faith in us. And so we want to have, you know, a credible budget whereby they feel, you know, confident in how we're moving forward. And that's, you know, that's tough in these times, you know, because it's still going to be a difficult conversation with the $7 million loss.
Thank you, Julie, for the report. Any questions for Julie on budget? Few, but I know you'll have some.
Yeah, maybe
Yeah.
not just acknowledging the Oregon Rebel, Dr. Gallagher and I had the pleasure of reviewing this information before me in the finance committee with Julie and her team. I really do appreciate the quality of the budget this year. It's phenomenal. I can imagine in your heads, you envision something entirely different, and you have an end state that looks nothing like this because you're self-drive to keep improving. But this is a dramatic improvement over what we've been doing, and historically, you know, prior to us being when it was just a community board and for-profit hospital, there's almost no information. So I just would acknowledge in a couple of years you guys have built a system that allows information to come. And while it is heavily Excel and manual, I appreciate the direction in which we're going and our ability to dive into numbers a little bit deeper than we've seen in those, especially in that first year. It's unnerving for our board to consider adopting a budget with the $7 million structural deficit, but I do acknowledge that as our EBITDA deficit is actually 5 million, so to a certain extent, our actual operating is a little bit better than the 7 million. EBITDA includes things like just talking about depreciation amortization for our CT and MRI scans. It's a non-cash transaction, but that falls down to the bottom line. So our, you know, at a minimum, we want to solve for that $5 million number. We heard earlier today that there's something like they took care. We were asking the finance committee, what would it take to get to a balanced budget? You know, how do we solve for $5 million? And part of that might be adding volumes in for Cadillac for sure. Part of it might be some better news on block 9, although we can't count on that in this environment. But things like the intensive care unit, that's the place we're going to have a struggle, and that's a place as a board. It's going to be our challenge to work with staff and set a realistic expectation. How do we get this right sized? We don't have the luxury of cash to navigate even a $5 million real loss next calendar year. So I think this is the budget that we should adopt. The finance committee recommends adopting it. We've gone through the assumptions. There are some areas that things could turn out better in this scenario. And there's work to be done. So I hope that makes some sense. But again, from a place of earlier comments, this is happening to us, not by us. And I appreciate how we keep responding to adapting to the new moment. This is us adapting to a new moment of lowering our expectation, lowering our revenue projections, and really presenting a budget that, as you say, Julie, allows us to tell our stakeholders is credible and you can count on it. So I just appreciate the work, and I'll end my commentary there.
Any additional questions before? I have a couple, but I think I'd open up to public comment and come back for questions. If that's okay. Okay. I'm going to open up item number 6 for public comment. Anyone, we'll start online first. Anyone online wishing to speak on item number 6?
No hands online.
Okay, anyone in person wishing to speak on item number 6? Okay, seeing none, I'll bring it back to the board for additional questions, comments, and discussion on the budget approval. Yeah, I want to echo what Director Pimentel just said. It's not typical for a government entity to approve a budget with a loss, right? You typically have to, well, we just saw the school district do it 2 years in a row, but it's not common practice, right, for government entity to approve a budget with a loss, and I think that is the timing of it, and as Director Pimentel said, as a result of things that are and continue and have happened to us, and with a mix of things that are a result of some investments that have not paid off yet. You know, and just to be 1,000% transparent with staff and community and all those things, right? We made some calculated investments that we have yet to see a return on. And, you know, we take as a board responsibility for those decisions. I do have questions about a couple of things, Julie, on the budget. The 43, the dish quaff IGT, in there it said IGT was about 1 point something million, and that's part of the new programs that we bought into. I'm wondering what the breakdown is for dish and the quaff.
Yeah.
If you have them.
I can give them to you in
Yeah.
kind of high level numbers, because you saw a number on the IGT that was a net number of like 2.4 million, because that's net of revenue and expense. And so from a revenue standpoint, we have about 5.4 million in IGT money coming in.
Okay.
We have about 18 to 20 million of QAP 8, I think still left to get. I think it's about 18 million, and then the remainder, so 18 by 23. So the other 20 million or so is the QAP 9.
Okay.
If I'm doing my math in my head right. And so many times I look at these as the net numbers versus just the revenue piece, because the expense piece falls down below the line. Part of the QAP 9 piece though is, besides that the amount could vary, is the timing.
Right.
Since we don't have an approved program yet, our best kind of scenario is that the timing would follow similarly to QAP 8, and even though the program is, you know, the program's run in arrears, so it's the 2025 program that starts to pay over like 26, 27. So even the payments for that don't come in until at best the end of 26, the beginning of payments, and some of them will spill over into the next year.
Mm-hmm. And so for that final payment of, just for my knowledge, for that final payment of the 8th cycle, when do we have an expectation of when that comes in, or is that, I don't know how.
That's in October of 26.
Okay.
But it is one where we're already sometimes advancing against
it,
those
right.
monies to help cover the shortfall.
Mhm.
And one other thing I realized when I was giving you those numbers is I didn't really speak to the dish portion.
Right.
So the dish portion of those funds is about, I think it's about $1.4 million, $1.5 million.
Right.
So back that off of that last
the
20
remainder.
that I threw in there. So it'd be about 18 and a half.
Okay. Yeah, I think the last that I saw from just feels like high school drama every time that I read about the program. And I think the last update that we got, at least publicly, right, is from the CEO of the California Hospital Association, just that they're in constant conversation with the department here locally, and they have to respond to CMS by January or whatever it is. And so there's, I think, a decision on QAP 9 and what that looks like and how we can project not only the 26, but then into 27 and so on and so forth. I think that's, I think it's something that we, obviously we have to put pen to paper and put something together on our budget. I even feel a little queasy of putting that 43, that figure there, and But the alternative is we put nothing there and then it just looks crazy, like a $30 million loss or whatever it is. And so I understand the figure. And like we just talked about, things that are happening to us and things that are not out of our control. We're simply taking care of the people who live in our community. So it's just, we had a presentation earlier this week and we talked about, well, what are the challenges facing Watsonville Community Hospital? And someone went down the rabbit hole and I think 3 or 4 of us said, yeah, the healthcare system that we're operating in. So those are always difficult conversations. I'm wondering, I don't know how or, and in what sort of, movement this creates, at the federal level, but just, giving an update to our congressional representatives, Jimmy Pineda, Zoe Lofgren, of how essential this is for us. I'm sure they're hearing it from everyone, up and down the valley and and over the hill in Santa Clara, just how essential this program is for their budget as well. And everyone's dealing with this, but, we've done some advocacy for the state legislature for some dollars. I'd like to do that. And Steve, I'm happy to help with that, with language and all that stuff as well. So just any way that the board can be helpful in moving along those conversations, I think would be great.
I will say to that point, because I do a quarterly update to DHCS and to HCI, that in every quarter, we can talk
What's
about
happening?
what's happening. We give them a, kind of a full plan of these were things we were working on, here's where we're at with them, and here's how much we're relying on, needing to get an answer and hopefully a favorable answer
Right.
to that question. And we give them a 24-month forecast.
Thank you for that. That's great. It's almost, I think it's the second year, maybe third year. Nancy's not in the room with me this year. But it's just asking for additional dollars for the marketing department and staring at a $5 million loss is really difficult. But I think the potential of using some of the bond dollars after the MRI and the CT scanners are installed and fully operational as a way to, whether it be a nice big sign over by our monument signs of saying, come get your procedures done here. I don't know how appealing that is for people to come get an MRI. We're going to have music playing during your MRI, right? I think that's one of the things. So, give us your playlist. We'll play it for you while you get your MRI. I just don't know how to market that to our community, but that is something they have invested into and something that I hope that those numbers are, like you said, really conservative numbers in the way that we're saying, this is our current capacity. How do we expand that, right? The $6,000 in the marketing budget hurts to see, and I understand it. And I'm wondering if we can do some shoulder tapping of our partners through our foundation with June, and just saying if there's any dollars across the state through some foundations that could potentially come to us to help bolster that, right? Because that's a big part of it. We haven't even done in my opinion, the full-on marketing push that I would like us to do in terms of the new logo and kind of new rebirth of the entity of the hospital on its own, right? And so I don't know if, we make a phone call up to Aptos and talk to our good friend Susan True and see if there's any dollars available through a community foundation or something like that to help us bolster some of those dollars and just get the word out, that public education about the hospital services available here, those things to boost that. And it's not gonna change it in 6 to 12 months, but that's how these sort of changes happen, right? The payer mix and the people who come in to use the services and all those things. So happy to work on that with you guys as well too. And then the other question I have is, I'm wondering, we showed the side by side of the hospital, the clinic, and the district. I'm wondering how the foundation factors into that, and if they're now fully paying for their staff, or are we still supplementing them, and is that in the budget?
They have their own separate budget. They're a separate entity, so we do still pay for their staff, so,
Okay.
you know. And so what's in the budget is, you know, the subsidizing expense, but then also a projection of what they're going to return to the hospital in terms of
Okay,
donation, you know, donated equipment or, you know, financial support.
so that is in the revenues, the dollars being brought in by the foundation. Okay, good to know. And then, two, like just, one, if we can dig in a little bit more, Julie, into the hospital KPIs, I think it was 8.4%. And maybe we go back to that slide, Rosie, if that's possible, just for my information and, what that means, so I can understand it. And apologies, I wish I was in the committee with you, I just. Yeah, that slide right
Yeah,
there, yeah. So can you explain this to me again, Julia? I apologize, this is, I'm thinking of people losing their health insurance next year, still showing up here, and is that related to this in terms of the level of acuity and people showing up in the actual? That's what I'm trying to factor in, and
Yeah,
yeah,
there's so many factors that go into this. Bad debt as a percent of collectible revenue ends up
Right.
taking in, you know, what is our historic percentages been, what is our payer mix, you know, assumptions. And again, most of it, this is really on the base budget, and we don't have a good way of determining like where and when we're going to lose volume as a result of HR1. I mean, we did
Right.
budget for overall less net revenue by basically putting a plug in there that says we're gonna lose like, you know, $5 million of you know, net revenue. That's our guesstimate. But we don't really get into the details of trying to figure out where, because we don't have good insights into that.
Mhm.
So it's factored in kind of underneath it, but really it's factored in, that's factored in at 100%. And so this is like, in what's left, we expect our net revenue, or our bad debt as a percent of collectible revenue to stay the same, because we've
Okay.
already just pulled out 100% of that
I
$5
see.
million.
Oh, I see,
Yeah.
okay, yeah, that's great to know, yeah, that's how we're using it, because okay, I understand the 8.3% now. I would have thought it would have been higher with everything that is changing, but I understand
Yeah.
now using that as the projected loss of just the overall kind of assumptions that we have from the projections that we have, I get now. Yeah, there's been great work being done by community organizations and by local governments. I think the County of Monterey said that they had or saw a 16% increase over, I think, the last 3 months of people signing up for Medi-Cal, which is awesome. And that's across the County of Monterey. I don't know how, I think the Benefits Collaborative that we sit on through Community Bridges was saying that they've seen an uptick in the number of people who have signed up for Medi-Cal as well too over the last 3 months. And so crossing my fingers that helps in some significant fashion for us. But, you know, we know that people are going to get kicked off, and even for people who don't. I think you made a comment earlier about the level of acuity going up higher, right? People delaying care, and the cost of care going up because of that. And then the only other question I have, Julie, is, and Mark and Director Pimentel knows this, but the recent numbers from the governor's legislative analyst office, I'm sure you've seen this, projecting $18 billion loss at the state level for 26-27. I think this last year was 16 or whatever it was, and they ended up cutting Medi-Cal, and that was the reason why, you know, people who are have unsatisfactory documentation status. Huge part of the projections as to the losses to local hospitals. I'm wondering if we're factoring that in at all to this budget, and what potential implications that might have. Or if that's a 27 question, or I guess discussion. I just don't know how we even like account for that. And to your point earlier, bringing these really difficult conversations, that this is not just going to be a 1-year reduction that we're seeing. This is going to be really challenging 3 or 4 or 5 years. So I just don't know how we account for that, or if we're even thinking about that yet in this budget. Yeah.
Well, I mean, I think, it's really the assumptions we've made around HR1 and some of the presentations that we've done in the past where we've said, we've got this range, because it can be like
Okay.
an all or nothing, and it can be these different things coming in at some happen in, 1/1/26, some happen
Right.
at, the end of 27. And so, like 5 million is our kind of starting point, and again, that was kind of in the middle of our range. But you look at our year 2 and it was, it's another $6 or $7 million. And so maybe we will learn something more about it this year that,
Yeah, I know.
it's hard to even think
Yeah.
about how you could get real granular with that stuff other than just watching what's happening to your population.
Exactly. Yeah. Okay. Those are all my questions. I don't know, anyone else, any comments or additional questions? And obviously we have to, there's a recommendation to pass a resolution to approve this year's fiscal year budget, as unorthodox as it is to, like I said before, as a government entity, to pass a budget with a significant loss that we're facing. But just Julie and team, just thank you. I know this isn't easy. And you're balancing numerous other things while also doing this. So just thank you, Julie, to you, to your team, Steve, for your leadership in this. Understanding that this is just really challenging times for everybody. And we got some work to do. Got a lot of work to do. So any additional comments?
Comment, and then I'm ready to make a motion. I recognize that January and February 2026 are going to be extraordinary in the level of information we find out and how specifically, immediately it impacts us. Fall 9 decision, January 10th, the governor's budget. I know we expect the numbers to be great. We'll have our audit maybe, March-ish, our audit done. So like this first 3 months, there's going to be a lot of quality data coming in that will help us, which will require us, I talk about the district's partnership conversations, right? That is setting it up for April to be a really important moment of time for this board, where we're going to be in a position to maybe have to make some really hard directive decisions, such as what you brought up earlier about things like the ICU. I'm not saying we're supposed to do that today, but like we're going to be, if by April things break the wrong way, this board will have to enter that month of April ready to take action to right-size our operations. And that's like by that date, no later than we may be required to do something sooner. With that, I'm ready to pass the staff recommendation to approve the adoption of our fiscal year 2026 budget.
Second.
Thank you, Directors Pimentel and Friel. I'll take roll on this item. Director Cox?
Yes.
Director Friel?
Yes.
Director Gallagher?
Yeah.
Director Pimentel?
Yes.
Chair News.
Yes. Okay, we're gonna move on to item number 7, Baja Valley Healthcare District 2025 Consolidated Audit Engagement. Julie.
Okay, this one should be a lot faster. It's that time of the year again. It gets here before we know it, because it usually takes us, a good 3 months to get through an audit, and then the next month to bring it back here for approval. So it's time for us to basically sign our audit engagement. We have elected to go with the same audit firm that we have used for the last 3 years, JWT and Associates. They know our organization. They've been the ones, Gerald's come and spoke to the board each time, talked about the going concern comments, talked about, they've been involved. We kind of use them throughout the year when we have questions about the bond or how to, record a certain thing. And so we just felt like in the interest of effort, resources, and that they know our organization well, that it would be wise to go with them again. And so we have the audit engagement letter in your package. We're ready to sign upon your approval to use them.
Any questions for Julie about this item or for staff? No. Okay, I do have to go out to public comment on this. Anyone wishing to speak on item number 7 online? Please raise your hand. Okay, seeing none, anyone in person wishing to speak on this item? Okay, seeing none, I'll close down the public comment for item number 7 and bring it back to the board for an appropriate motion.
I'll move approval, just recognize that the finance committee reviewed this and also recommends the second.
Can I get a second? Second.
Thank you, Directors Pimentel and Gallagher. I'll take roll on this item. Director Cox?
Yes.
Director Creel?
Yes.
Director Gallagher?
Yeah.
Director Pimentel?
Yes.
Attorney Lewis?
Yes. Okay, we will now move on to item number 8. This is the organizational meeting and election of the 2026 Watson Community Hospital Board officers. There's two recommendations in front of the board. One is to present the Watsonville Community Hospital Board members with the information necessary to be prepared to elect officers for the offices of chair, vice chair, treasurer, and secretary during the January 28, 2026 regular board meeting, and 2, to pass a motion to form an officer election nominating ad hoc committee of less than a quorum of the board and appoint a committee chair. Okay, see.
Yeah, I see my name there, but you read it for me. I don't have anything else other than to say this is just, following our hospital bylaws, right? We have the opportunity, the nominations don't happen at this time, they happen in January, but we have the opportunity if you would like to create an ad hoc nominating committee.
I can do that as the board chair, or we can do it as through a vote, which I would like the latter if the board is so keen on that. I will just give some background information for those on the board who are uninitiated of the last couple of the last 2 years. So 2024 in terms of the hours per week, I would say. In 2024, just kind of briefly in the immediate from my perspective in terms of I know we're not nominating folks now, but just from my perspective in terms of the hours spent of being and serving as the board chair as we start this process. 2024 was anywhere from trying to go back and track hours was around 5 to 10 those first couple of months after I took over after the sudden passing of John, and then the rest of the year was about 5 to 7. This past year was probably about 10 to 20. And so, and I imagine that the rest of 26 is going to be about that, and probably 27 as well. So, not to deter anybody, but just the reality of that. And so we have 2 recommendations in front of us, and obviously the second one is the motion to pass the recommendation to pass a motion to form an ad hoc committee of 2 members to appoint a committee chair to lead the nomination process. Open to anybody willing to serve on that at this time. And also am willing to serve on that committee if the board feels so inclined to select me.
I have a probing question first, before we go there. I recognize that 4 of the 5 of us are officers. And I'm just wondering if the 4 of the 5 of us are all willing to continue in an officer role the next year, or if there's any I just want to affirm that everybody's willing to continue in an officer role.
I'm willing to continue with my non-nonprofit.
I appreciate that. Thank you.
So we're not appointing anybody to the board, or I'm sorry, to the, to any officer role today. We are, establishing an ad hoc committee, to go through that process, but that is, good information there. Does anybody have a recommendation or a nomination for the ad hoc committee? Again, I'll say that I'm happy and willing to serve on the committee if nobody else would like to.
I'll happily join the nominated ad hoc member.
Okay, we have a motion to realize, well, we first need to go out to public comment on this, sorry about that. So if there's no other questions for staff about this item, I can open up to public comment, okay? All right, so I'm gonna open up to public comment on item number 8. Anyone online wishing to speak on this item, please raise your hand. Okay, seeing none, I'll bring it back. Person? Seeing none, I'll bring it back to the board for an appropriate motion.
Chair, before we go
Yes.
on that, we want to roll the assignment of the chair of that ad hoc into this.
Yeah, it's, yes, it's, part of that, the second part of the recommendation. So it is to pass a motion to form an officer election nominating ad hoc committee and list a form of the board and appoint a committee chair. Did I understand the question correct?
So you're hoping that somebody's motion includes all of it together?
Yeah.
Yeah.
2 members
So I have
and
the
the
two
chair.
members, and who then like to be the chair of that.
Oh, great.
So I'll motion, with staff's recommendation as described here, that we form an officer election nominating ad hoc committee. That it shall consist of myself and Chair Nunez, that I will serve as the committee chair.
Thank you. Second. I'll take the roll on this item. Director Fox? Yes. Director Friel?
Yes.
Director Gallagher?
Yeah.
Director Pimentel?
Yes.
Chair Nunez?
Yes.
Thank you.
Okay, we'll move on to item number 9. This is the Chief Executive Officer Annual Review. Recommendation before the board is to pass a motion to form a Chief Executive Officer Review Ad Hoc Committee of less than a quorum of the board and appoint a committee chair. So similar to that, and the contact here is Margaret, but Steve, if there's anything you'd like to add to that?
No, I appreciate the diligence with which you give me feedback, so thank you for that in advance.
Of course. So just, so this is to appoint a review ad hoc committee, and I believe last year I was able to kind of pull the number of meetings and presentations that both Director Pimentel and I gave as while sitting on the ad hoc committee. So there was 2 items that committee did, and one of them was both a performance review and then also goal setting. And overall, there was about 10 meetings and about 3 presentations, all of various kind of capacities. I believe 2 of them in closed session, 1 of them in public, that they were Director Pimentel and I were putting on over the course of about 3 months, if I remember correctly. So not light work, but very rewarding work and essential work to ensure that our leadership has the direction they need and then understands, what we're looking for in the hospital. And obviously, different times, which we'll be doing, as a board, this review. And as Mark has said, right, in a previous item, a lot of things up in the air, and April looking like a time in which we will likely have a sense of direction of what 26 might look like, or more clarity, I should say. So that's just some background there. Anything else, Director Pimentel, that you wanted to share about the previous year, the scope of work or workload of being on that, review. That,
In the last 2 years, in a good way, they've been. They require an extraordinary level of board level work in developing the process. And I think I appreciate and recognize that with our CEO, our hospital system just doesn't have the data. Right, I mean, recharacterize that. In the past, when the board has identified the kind of quality metrics we wanted to use, it was hard to find the data sets that feed that. I think we're starting to develop some of that. So I don't want to jinx it, but I'm optimistic. It may not require as big as well, but we'll see. We'll see. Still requiring, we still have a lot of manual data that lives out in the universe. With that, I'm willing to continue to serve at the board's pleasure on the ad hoc.
any questions or, comments before I open up to public comment, from the board? Okay, I do want to open up to public comment. Anyone wishing to speak on this item, online? Okay, seeing no hands. Anyone, with this in person wishing to speak on this item? Okay, seeing none, I will close down the public, comment, bring it back to the board for additional discussion and an appropriate motion on item number 9. Now I will just start, and echo Director Pimentel's comments and say that I learned a lot about putting together the process last year, and felt like we put together a list of goals that were a reality for us as we were putting them together throughout the back end of 2024, and this coming year is going to be a little bit different. So just want to, recognize that. And I also willing to serve on this and continue that, continue the work that Dr. Pimentel and I did during last year's review committee. Although I do think it is a great opportunity for any additional board members, given the workload is available. And so that's always, but I'm willing to serve on this as well. Any additional comments or any potential? Then I'll jump in.
I'm willing to serve, but I don't want to rock the boat. I am willing to serve on there though. If someone wants a break, but I don't need to be pushing myself back.
I'll move toward a motion that we do form the ad hoc committee. Less than a form is 2. That it would be again myself and Chair Nunez. And I'm willing to serve as the chair for the CEO officer review.
Can I get a second?
Second.
Thank you. Directors Pimentel and Friel, I'll take roll on this item. Dr. Cox?
Yes.
Director Friel?
Yes.
Dr. Gallagher?
Yeah.
Director Pimentel?
Yes.
And Chair Nunez.
Yes, and just a point of order, you said directors Pimentel and Friel.
That was close.
Is that,
Pimentel and Friel for the motion.
the motion? Okay.
But directors Pimentel and Nunez to serve Pimentel as the.
It was.
It was,
Sorry.
Okay.
Thank you.
Okay, that brings us to the end of the Watson Community Hospital Board